Hello and welcome to yet another session of Brandos. Good evening, everyone, for joining us, taking out your precious time, and to join us again on our this academic platform. For those who are new to this program, Brandos is an online learning platform where, on a monthly basis, all the clinicians with a special interest in breast and endocrine surgery they join on every last Friday of the month at 7 p.m., where we discuss about breast and endocrine related problems on alternate basis. So we have breast meet on every even month and endocrine meets on every odd month. Now February being an even month, we have a breast meet. In this program, we have a multidisciplinary approach. We pick a case with some specific issues. We discuss about that case in detail with the original images, the intraoperative pictures, the postoperative follow-up, so that all those who are ever involved in the management of that case, they have an impact in the mind how these images look like, what are the impact of the reporting on the ultimate management of the patient and the follow-up of the patient, so that not only the surgeon or the clinicians who are directly involved in the management of case, the pathologists, radiologists, nuclear medicine physicians, all those who are ever involved in the management of case, they know about the basic detail and the ultimate outcome with the management of the patient. Fine. This time also we have a very interesting case and a very interesting topic also. This time we have picked a case who had a controversial pet reporting, and based on which we tried our best to learn about the basic molecular imaging, their impact, advantages, disadvantages, and limitations. To know more about now, I request our moderator, Dr. Avdesh Pandey. Dr. Avdesh Pandey, sir, is a nuclear medicine physician. He is the head of Department of Nuclear Medicine at Subharti Medical College at Meerut. And he kindly consented. He is a great academician and a great clinician also. And I request Dr. Avdesh Pandey, sir, to put a light about this topic and to introduce our speakers and the guest faculties and to start our program.
Anand. Namaskar and a very good evening to everybody. I hope I'm audible. It's a wonderful evening to be with you all, and the topic is cancer breast and fallacious reporting as far as a PET CT or a molecular imaging is concerned, and how it impacts the patient positively or negatively, or for that matter, how does it involve in the management of the patient. Now, with this topic, I would like to give a small backdrop of imaging has revolutionized medical practice right from the days of when it was first introduced. The first person to get a Nobel Prize ever was Röntgen for X-rays. That was in 1900. Since 1900 till now, the journey that we have seen, imaging has revolutionized medical practice, whether it is surgery, interventional or non-interventional practice, both have been revolutionized by imaging as such. Now, imaging can be categorized into three categories: anatomical, physiological, and biochemical imaging. Anatomical imaging, we all know X-ray, CT scan, MRI, ultrasound, angiograms are anatomical modalities of imaging. The physiological and the biochemical modalities of imaging remain the domain of a functional imaging group. So nuclear medicine developed as a physiological and the biochemical imaging modality. Today, diagnostics are the bottom line from which we start our workup, whether it is medical or surgical workup. Now, in vivo imaging, that is live imaging, because anatomical histopathological imaging is imaging of dead tissue. I mean, that is an image that is produced. The diagnosis is reached with dead tissue. You never know the composition of a dead tissue and a live tissue. would be different. But here in PET CTs, in molecular imaging, we are imaging live in vivo tissue, and we are coming to a conclusion. So this scores over many modalities. Yes, there could be fallacies of reporting, there could be error of judgment. That is always there, and that should be taken into account, whether it is any kind of imaging that is being rendered as service to the patient and the doctor concerned. With this, I would like to start on our Dr. Sudhi. The guest faculty, Dr. Aftab is there from Sanjay Gandhi PGI. Dr. Reena Dhamija is there from Meerut Imaging Center. And we have Dr. Geeta Kadeprat. Am I right in pronouncing?
You got it right, yeah. It's a tough one, I agree.
So Dr.
But
Geeta
very unique.
Yes.
So that's a South Indian
Yeah.
name, so I don't blame you really.
Yeah, and South India को hold करके रखा मैंने. Anyway, so she's an expert. She is an expert surgeon, and she is she has done her MBBS from Lady Harding Medical College. Okay, and MS from Maulana Azad Medical College, and FRCS from Glasgow. And she has a 24 years experience, over 24 years experience in breast surgery, in surgical oncology for that matter. And she is at the moment the director of Breast Society in the Max group of hospitals, which is at Patparganj and Vaishali. So with this introduction, she has many more things. I mean, she has a 2-page CV. Let me tell you that. And she's a very experienced faculty that we have. Now the second faculty that we have is Dr. Aftab. Dr. Aftab is a nuclear medicine expert from Sanjay Gandhi PGI. He's an associate professor there, and he has done his MBBS from Motilal Nehru Medical College, Allahabad, and then he has done his MD from All India Institute of Medical Sciences, where he has done his senior citizenship, senior residentship also. And then he has joined Sanjay Gandhi PGI, one of the premier institutes of the country, and he is managing nuclear medicine department there. He is an associate professor there with many other faculties there. It's a big department, huge department of nuclear medicine, worth visiting once in a lifetime. So that much I can say as far as Sanjay Gandhi PGI department is concerned. So we have a very rich faculty today. And with this, I invite the speaker to start the session.
Okay, thank you very much, sir. And a couple of announcements before we actually start our program. First of all, I request all those who are not presenting to keep their mic muted so that there is no interruption. In case they want to ask any question from our faculties or any one of us, they can write their questions in the chat box, which our moderator will note down with doctor's name, so that at the end of the presentation, those questions will be asked. In case you want to ask any question from yourself directly to the faculties or anyone else, then you please wait. At the end of the main discussion, you will be given the opportunity to discuss directly and interact directly with any faculty of your choice. Fine. In between, if you lose connection or you are accidentally left out, you please rejoin us by clicking the same link. And the other speakers, my colleagues who are presenting the cases, this program with us are Dr. Chani Jain. She is consultant pathologist from Shastri Diagnostics Center. Dr. Meena Bembi. She is consultant radiologist and head of Department of Radiology, Krishna Raj Diagnostics Center. Dr. Nitin Yadav. He is a consultant nuclear medicine physician at Valentis Cancer Hospital, Meerut. Dr. Reena Dhamija. She is consultant nuclear medicine physician at Meerut Scan Center, and myself, Dr. Sudhi Kamboj, consultant and head Department of Breast and Endocrine Surgery at Nutima Hospital, Meerut. So with this, now I am sharing my screen. So friends, as you know, today we are discussing about the molecular imaging in breast cancer, and we have the emphasis to discuss about the details what we as a clinicians must know. These faculties and the speakers already you know now. Dr. Aftab Hassan Nazar is kindly consented at the last moment to attend our program as a faculty. Thank you very much, Dr. Aftab. And now we present our case with a 60-year-old postmenopausal lady who was multiparous and who adequately breastfed her children, presented with a right retroareolar painless, non-progressive nodularity for last 1 year. It was so subtle that initially she was, for many few months, she remained doubtful whether it is really some important thing to discuss about or not. But after waiting for 1 year, she ultimately thought of showing it to a doctor. She did not have any other comorbid condition except that she had a past history of pulmonary tuberculosis around 10 years back, for which she received anti-tubercular treatment for 9 months. So when she came to us, her other clinical features were unremarkable, except there was a very subtle nodularity felt in the retroareolar region of the right breast. It was very subtle, but this was her nipple was fixed, more so in the upper outer part of the areola. So that was very subtle and suspicious, but still not clearly palpable. We, as a routine, asked her to get a mammography done, and I request our radiologist, Dr. Meena Bembi, to describe the mammography images to us.
Thank you, Dr. Sudhi. We did the mammography. On mammography, there was area of subtle increased density in retroareolar region. So we did collaborative ultrasound. On ultrasound images, next slide, please. On ultrasound, collaborative ultrasound, ill-defined hypoechoic lesion with speck of microcalcification was noted in 9 o'clock position periareolar location, which was extending to retroareolar region, and minimal increased vascularity was also noted within the lesion. So in view of the age of the lesion and the characteristics of the lesion, we put it in the category of BIRADS 4, and it was like suspicious lesion from our from radiological point of view, and further FNAC histopathological correlation was advised.
The lesion was very, very small, not palpable clinically. We were skeptical whether we'll get anything if we try Ruger biopsy or not. So initially we sent her for a guided FNAC, and I request our pathologist, Dr. Chani, to describe her FNAC reports with us.
Thank you, ma'am. So on FNAC, blood mixed material was aspirated, and the smears, they showed groups of atypical cells, as can be seen in the first photo micrograph. And on high power, if we see, so there were cells with high NC ratio and open chromatin, prominent nucleoli. And in the background, red blood cells and pinkish material could be seen. And the important point was that there were no myoepithelial cells visible in the clusters. So based on all these, next slide, ma'am. There is a comparative photo micrographs.
I request someone's mic is on. I request those who are not, excuse me, those who are not they may mute their mic. Yeah.
So here is a comparative analysis. If we want to see the photo micrographs, first one is of a normal cytology of breast, where we can see a monolayered sheet with evenly distributed cells, regular round, and the edge of the sheet, at the edge of the sheet, we can see myoepithelial cells. Now, as the lesion progresses to a proliferative disease, the clusters become more and more disorganized. So in the second photomicrograph of a fibroadenoma, we can see a branching sheet where there is multilayering of cells, and in the background we can see singly lined cells, which are the bare nuclei. These denote the myoepithelial cells and indicate a benign pathology. As we go to a malignancy, in the last photomicrograph, we can see there is more disorganization, cells are loosely arranged, and there is anisonucleosis, that is variation in size, and the chromatin is getting progressively more loose or open. So these are the classical pictures. Now in our case, if we see the lower image, it is of same magnification as the above images. So we can see there is a loose cluster with multi-layering, but the size of the cell was a little smaller than we usually find in IDC. But since there was absence of myoepithelial cells and the chromatin was coarse, so this was diagnosed as a suggestive of a ductal carcinoma.
So now this patient was now a diagnosed case of ductal carcinoma for us. As a protocol, any patient with ductal carcinoma, we asked for a screening for metastatic workup. So we asked her for a PET scan. The PET scan report I request our nuclear medicine physician, Dr. Nitin, to describe.
Thank you, ma'am. First of all, I would like to clarify that this PET scan is not done at our center, and I am just interpreting these PET CT images. Coming to first image, that is maximum intensity projection image, which show physiological uptake in brain, and also there is increased FDG avidity at bladder, which is route of excretion. And also there are small focus of increased uptake at bilateral lower neck region and thoracic paraspinal region. These are mainly physiological brown fat uptake because scan was taken in January. Because in winters, brown fat is usually seen. Now coming to abnormal uptake, there is a focal uptake at right upper thoracic region. Now coming to second slide, it is an axial section of fused PET CT image at the level of nipple. As we can see, there is soft tissue density lesion at retroareolar region of right breast with little FDG avidity and hyperdensity at nipple. When we look at the same region of left breast, it appears to be normal. Ma'am, next slide. Now, this first image is axial section of fused PET CT image in lung window. Here there is increased FDG avid consolidatory lesion at right upper lobe of lung, which is abetting pleura. And next image is sagittal section of fused image, which appears to be normal. So considering these findings, my opinion is that lesion at the right breast is suspicious in nature, and lesion in right upper lobe of lung is likely to be infective. In reporting, the right breast lesion was reported as non-FDG avid subcentimetric nodular lesion, likely to be benign, and right lung lesion was reported as infective.
Okay, so now the controversy, since we had this report, which reported the right breast lesion was non-FDG avid, and we had a report of FNAC suggestive of IDC. So there was some controversy. We discussed these things in detail with the patient, and we suggested the patient for excision biopsy. The lesion was very, very small. So we planned for a wide local excision, which amounted to a central quadrantectomy in her case. So this was the lesion, subtle lesion, and we did a central quadrantectomy. We did not do any oncoplastic procedure in her case. This is the gross image of the patient. The nipple is bisected from between, and this is the retroareolar, or just beneath the nipple, we found this suspicious lesion. And I request Dr. Chani Jain again to describe the gross and the microscopic images to all of us.
So we received the white excision specimen with orientation sutures in place, with a short suture denoting the superior margin and long suture denoting lateral margin. And just below the nipple, as we can see here, there was an irregular white area which measured around 1.5 into 1 into 1 centimeters. And all the margins were sufficiently away from the lesion. So on microscopy, as we can see here, first image, which is the low power view, on the on the right upper corner, we can see the epidermis, which is the epidermis of the nipple. And below this, in the dermis, we can see irregular infiltrating nest of tumor cells. All these blue clusters are the nest of tumor cells. Then on a high power, in the second image, we can see that they are forming tubules and nest. All these lumens, they are the tubules, and there are irregular nest and stromal changes are there. If in the lower left image, which is a 40 times magnification, we can see the chromatin is open and there are prominent nuclei in the nest. Another important feature which we saw was in the last image is the infiltration of fat. This is an important feature to differentiate it from certain mimickers of carcinoma, since in this the PET report was non-contributory. So this is also an important feature for indicating invasion. And a very interesting additional finding which I found was the presence of a granuloma, which we can see here, Langerhans giant cells, epithelioid histiocytes, and they were surrounded by a cuff of lymphocytes. So this was an additional finding which we also found. Based on all these findings, it was on histopathology. It was diagnosed as invasive carcinoma, no special type ductal of right breast, and Nottingham histological grade was grade 1. Further, immunohistochemistry was done, and estrogen receptor showed a strong positivity in almost 90% of tumor cells. Same with progesterone receptor. All this dark brown staining indicates positivity of the tumor cells. So as we can see, almost all of the tumor cells, they are showing strong positivity. So Allred score was 8/8 for both ER and PR, and HER2/neu was negative. Ki67 proliferative index was approximately 10%.
So for us, this patient has a clinical staging of, she was a diagnosed case of right breast cancer with a clinical staging of T1N0M0, that was a lesion less than 1 centimeter, with a pathological staging of T1NXMX. Since we did not do sentinel lymph node biopsy in her case, she was a luminal type A case, and we then sent her for radiotherapy consultation for breast and axilla. And also we planned her for adjuvant hormone therapy. Okay, so what was the cause? Why we put this case in this forum? We put this case in this forum so that we get an opportunity to discuss in detail about the basic understanding of the various molecular imagings in breast cancer, the various technical aspects of molecular imagings which clinicians must know. What are the practical applications, the advantages or limitations of these techniques, with an emphasis on PET scan and sentinel lymph node biopsies, which are frequently used by us, and what were the causes which led to not being so popular are the other techniques. What are the probable causes of the false negative uptake or false positive uptake in breast and lungs respectively in this case? Or if I summarize, what are the interpretation? How should we interpret any report of PET scan? Fine. So for this, we have two very important and very good nuclear medicine physicians with us. Those are very expert in their field, and I request to take over and to tell us about what is nuclear medicine.
Okay, thank you, Dr. Sudhi. So I'm just explaining basics of nuclear medicine. It is a branch of medical imaging which uses radioactive material called radio tracer, and this is basically known as radiopharmaceutical, which is administered to the patient. Next slide. This is used to diagnose and treat various diseases. Now, what is the basic principle? Basic principle is the radiopharmaceutical is having two parts. One is radioactive part, that is radionuclide or radioisotope, and another is pharmaceutical, that is specific for a particular organ. So we are just tagging radionuclide with the pharmaceutical, and when administered to the patient, this pharmaceutical goes to the particular organ and carrying along this radionuclide. and this radionuclide from that particular organ gives emission, and what we are getting on gamma camera or PET images, that as a emission imaging or hotspot, and we describe that particular organ function at cellular or molecular level, and that too is very early in the disease progress, and that's why we are also call this as molecular imaging. Next slide. Now there is basic fundamental differences between radiology and nuclear medicine. Radiology is basically a transmission images where X-rays are used in X-ray and CT machine, and they transmit it through patient's body and produces transmission images, and they give basically structural or anatomical information. As you can see the images below, mammogram, ultrasound, and MRI, they are just giving anatomical information and used for diagnostic purpose. Next slide. On the other hand, nuclear medicine, this is we are administering radiopharmaceutical to the patient, and from the patient becomes source, and then this give emission now. So emission images are formed, and we are getting this shown in the this image as hotspot. Below images, you can see these are molecular breast imaging. This is lymphoscintigraphy, and right one is a PET scan. These all are showing hotspots. That is basically emission imaging, and they are giving functional imaging, functional information, and from the cellular level very early in the disease. Then, what are the types of molecular imaging in breast cancer? There are studies in three categories. One is breast, so looking for tumor or primary lesion in the breast. And second, locally advanced or lymph node involvement, axillary or extra-axillary, just to make sure for the proper planning of the surgery. And third is the whole body imaging. Whole body, just to look for spread of the disease in whole of the body or the metastasis.
So, friends, like if I put this image, you can see that all these breasts are normal looking. Only difference is in the density. So, this density may vary from patient to patient. This patient has a very fatty breast, then mild density, moderate density, and high density. So, where the problem comes? Problem comes when a subtle lesion is present in a breast and the breast is dense. In a fatty breast, a subtle abnormal lesion is highlighted very good, highlighted very brightly. But as the density increases, this lesion is masked in the density of the breast. And here comes the role of nuclear medicine. Dr. Nitin will describe more about it.
थैंक यू मैम। जैसे कि मैम ने बताया कि जैसे जैसे ब्रेस्ट में डेंसिटी इंक्रीज होती है, लीजन का लोकलाइजेशन डिफिकल्ट होता जाता है। इसमें ये न्यूक्लियर मेडिसिन इंपॉर्टेंट रोल प्ले करता है, क्योंकि मेनली फंक्शनल इमेजिंग है, जिसमें कि जो हम रेडियो ट्रेसर देते हैं मेनली कंसंट्रेट होता है लीजन। जैसे कि करस्पॉन्डिंग इमेजेस में आप देख चुके हैं, फर्स्ट इमेज पॉजिट्रॉन इमिशन मैमोग्राफी की है, जिसमें कि ब्लैक स्पॉट, जैसे कि हम हॉट स्पॉट भी बोल सकते हैं, जो कि हमें ट्यूमर लोकलाइजेशन में हेल्प करेगा और हम इजीली लीजन डिटेक्ट कर सकते हैं। जबकि कॉरस्पॉन्डिंग मैमोग्राफ इमेज में ड्यू टू इंक्रीज डेंसिटी ट्यूमर लोकलाइजेशन डिफिकल्ट। नेक्स्ट इमेज। अगर हम ट्रीटमेंट रिस्पांस की बात करें तो उसमें भी फंक्शनल इमेजिंग इंपॉर्टेंट रोल प्ले करती है। ये इमेजेस उसका एक एग्जांपल है, जैसे कि पेशेंट में एमआरआई, ब्रेस्ट एमआरआई और डेडिकेटेड ब्रेस्ट पेट बेसलाइन पे किए गए, तो दोनों में लीजन पिकअप हुए, जो कि ऑरेंज एरो से आप लोग देख पा रहे हैं। आफ्टर 3 वीक्स ऑफ थेरेपी एमआरआई ब्रेस्ट में कोई चेंज नहीं है, लीजन वैसा का वैसा ही है, बट डेडिकेटेड ब्रेस्ट पेट में कोई स्पेसिफिक अपटेक नहीं है, जो कि ये शो करता है कि जो भी ट्यूमर था वो अब वहाँ पे नहीं है। तो इससे मेन इम्पैक्ट ये पड़ता है कि मेनली फंक्शनल चेंजेस एनाटॉमिकल चेंजेस से पहले होते हैं। नेक्स्ट स्लाइड। नाउ टॉकिंग अबाउट मॉलिक्यूलर इमेजिंग इन ब्रेस्ट, there are mainly 2 types of imaging modality. One is SINTI mammography, जिसमें कि हम गामा कैमरा का यूज करते हैं, दूसरा पेट इमिशन मैमोग्राफी, जिसमें कि डेडिकेटेड पेट मशीन का यूज होता है। दोनों में मेनली डिफरेंस ये है कि हम सिंटी मैमोग्राफी में सिस्टम ईबी का यूज करते हैं और पेट मैमोग्राम में एफडीजी का यूज होता है। नेक्स्ट स्लाइड। ये दोनों इमेजिंग मेनली बेसिक अंडरस्टैंडिंग के लिए हैं कि मशीन कैसी दिखती है और हमें इमेजेस कैसी मिलती हैं। जैसे कि फर्स्ट इमेज एक मॉलिक्यूलर बेस्ड इमेजिंग है, जैसे सिम्टम मैमोग्राफी, जिसमें भी इंजेक्शन के बाद में हम ब्रेस्ट को दो डिटेक्टर के बीच में प्लेस करते हैं और फिर इमेजेस ली जाती हैं। और ये इमेजेस कुछ ऐसी दिखती हैं जो कि आप देख सकते हैं, जो कि ऑरेंज एरो है वो शो कर रहा है इंक्रीज रेडियो ट्रेसर अपटेक, जो कि ट्यूमर को डिपिक्ट करता है। और कॉरस्पॉन्डिंग मैमोग्राफ को देखें तो लीजन लोकलाइजेशन उतना अच्छा नहीं है। दूसरी इमेजेस मेनली ब्रेस्ट मैमोग्राम और डेडिकेटेड ब्रेस्ट पेट दिखाती है, जिसमें कि प्रोन पोजीशन में इमेजिंग करती है। और दोनों ही मॉडलिटीज में हमें इमेजेस कैसी मिलती हैं वो दिखा है। और डेडिकेटेड ब्रेस्ट पेट में हम लीजन को मेनली इंक्रीज ट्रेसर अपटेक से लोकलाइज कर सकते हैं। Now talking of SINTI mammography, SINTI mammography में हम मेनली टेक्नीशियन 99 सिस्टम ईवी रेडियो फार्मास्यूटिकल यूज करते हैं, जिसका कि 90% लोकलाइजेशन डेंस माइटोकॉन्ड्रिया में होता है, जो कि मैलिग्नेंट सेल का कैरेक्टरिस्टिक होता है। इसका अपटेक मेनली रीजनल ब्लड फ्लो, ट्यूमर एंजियोजेनेसिस और इंक्रीज मेटाबॉलिज्म पर डिपेंड करता है। बट सब्सिक्वेंट इमेज में जो हम डिलेड इमेज लेते हैं, कुछ पेशेंट्स में हमने ये देखा है कि सिस्टम ईबी का रैपिड वॉश आउट हो जाता है, जो कि कोरिलेट करता है ट्यूमर सेल्स पे पी ग्लाइकोप्रोटीन के एक्सप्रेशन से, जो कि एक प्रोटेक्टिव ट्रांसमेम्ब्रेन प्रोटीन पंप होता है। और पी ग्लाइकोप्रोटीन का एक्सप्रेशन डायरेक्टली कोरिलेट करता है ओवर एक्सप्रेशन ऑफ मल्टी ड्रग रेजिस्टेंट जीन इन द ट्यूमर सेल, जो कि हमें एंटी कैंसर ड्रग एफिकेसी का एक बेसिक आइडिया देती है कि जिन कैंसर सेल्स में एंटी पी ग्लाइकोप्रोटीन का एक्सप्रेशन ज्यादा होगा उनमें सिस्टम ईबी का वॉश आउट भी रैपिड होगा, और ऐसे केसेस में एंटी कैंसर थेरेपी उतनी इफेक्टिव नहीं होगी जितनी कि अदर केसेस में होगी। नेक्स्ट स्लाइड। और डिस्पाइट ऑफ हैविंग हाई सेंसिटिविटी एंड हाई स्पेसिफिसिटी, especially in dense breasts and breast with implants, सिंटी मैमोग्राफी की अपनी लिमिटेशन है। मेनली सिंटी मैमोग्राफी रेगुलर मैमोग्राफी को रिप्लेस नहीं करती है, और इसमें जो लीजन जिनमें कि इन्फ्लेमेशन होता है या फिर सर्जरी या फिर हाइपर प्रोलिफरेटिव रीजन है, उसमें फॉल्स पॉजिटिव के चांसेस ज़्यादा हैं। सिंटी मैमोग्राफी में का रेजोल्यूशन कन्वेंशनल इमेजिंग के मुकाबले कम है, और ये एक टाइम कंज्यूमिंग प्रोसेस है। अगर हम मेनली अगर एक्सपोजर की बात करें तो सिंटी मैमोग्राफी में 6 to 9 मिलीसीविट का एक्सपोजर होता है, जबकि एक्सरे मैमोग्राम में 0.4 मिलीसीविट का ही यूज होता है। इन सारी लिमिटेशन को ध्यान में रखते हुए ही सिंटी मैमोग्राफ एक स्क्रीनिंग टूल नहीं है, ये मेनली सस्पिशियस केसेस में ही यूज किया जाए। नाउ टॉकिंग अबाउट मॉलिक्यूलर इमेजिंग इन ब्रेस्ट कैंसर, फॉर सर्जिकल प्लानिंग में मेनली हमारा फोकस होता है कि हम एक्सरे नोड्स को मेनली मैप करें, सेंटिनल लिम्फ नोड डिटेक्ट करें और सेंटिनल लिम्फ नोड बायोप्सी को असिस्ट करें। In 1940s, studies by Gilchrist, Zidman and Buss demonstrate that metastatic cell spread through regional lymphatics in an orderly and reproducible manner, thus paving way for evolution of sentinel lymph node biopsy. Sentinel lymph node बोला जाए तो पहली lymph node होती है जो कि एक ट्यूमर से ड्रेन करती है। और next slide. And it acts as a watchdog which watches over drainage of tumor from that region. Next slide. अब ये क्वेश्चन आता है कि सेंटिनल लिम्फ नोड की बायोप्सी क्यों इंपॉर्टेंट है। तो सेंटिनल लिम्फ नोड की हिस्टोपैथोलॉजी में देखा गया है कि अगर सेंटिनल लिम्फ नोड में कैंसर सेल डिटेक्ट नहीं होते हैं तो मोर देन 95% चांसेस हैं कि अदर एडजेसेंट लिम्फ नोड्स भी नॉर्मल होंगी। नेक्स्ट स्लाइड। और अगर सेंटिनल लिम्फ नोड की हिस्टोपैथोलॉजी में कैंसर सेल्स मिलती हैं देन एक्सटेंसिव एक्सिलरी लिम्फ नोड डिसेक्शन की नीड होती है। लिम्फ नोड मैपिंग के लिए मेनली 2 स्टेप्स होते हैं कि हम प्री ऑप लिम्फ नोड सेंटीग्राफी में एक्सिलरी लिम्फ नोड मैपिंग करें और इंट्रा ऑप सेंटिनल लिम्फ नोड डिटेक्ट करें और बायोप्सी। लिम्फोसिंटिग्राफी कुछ इस टाइप की दिखती हैं। ये फर्स्ट इमेज एंटीरियर पोस्टीरियर इमेज है और सेकेंड इमेज लेटरल इमेज। ये दोनों प्लेनर इमेजेस हैं जिसमें कि लार्जर ब्लैक स्पॉट हमारा इंजेक्शन साइट है और स्मॉलर ब्लैक स्पॉट हमारी सेंटिनल लिम्फ नोड है, जो कि हम इजीली डिटेक्ट कर सकते हैं। सेंटिनल lymph node mapping technique mainly used for identification of lymph drainage basin, to determine number of sentinel lymph node, to differentiate sentinel lymph nodes from subsequent nodes, to locate sentinel lymph node at an unusual location, and to mark sentinel node over the skin for biopsy. For procedure of sentinel lymph node mapping and biopsy, हम बेसिकली रेडियो कोलॉइड इंजेक्शन देते हैं जो कि 2 to 3 ml वॉल्यूम का होता है।
I'm sorry.
मैम प्रीवियस स्लाइड।
Previous slides. Fine. Sorry. Yeah.
मेनली 3 स्टेप्स हैं जो कि फर्स्ट है इंजेक्शन, फिर प्री ऑप सेंटीग्राफी जिसमें कि हम लिम्फ नोड मैपिंग करते हैं और लिम्फ नोड को मार्क करते हैं, फिर इंट्रा ऑपरेटिव गामा प्रोब की हेल्प से सेंटिनल लिम्फ नोड लोकलाइज की जाती है जो कि फिर बायोप्सी के लिए जाती है। नेक्स्ट 3 मेन पैरामीटर जो मेनली इंपॉर्टेंट होते हैं लिम्फोसिंटिग्राफी में, वो है इंजेक्शन साइट, इंजेक्शन वॉल्यूम एंड इंजेक्शन एक्टिविटी। फोर्थ पैरामीटर है टाइम, द टाइम इंटरवल बिटवीन इंजेक्शन एंड सर्जरी, बिकॉज जो कि डायरेक्टली कोरिलेट करता है अमाउंट ऑफ रेडियो एक्टिविटी इंजेक्टेड से। नेक्स्ट मैम एक क्लिक और। फॉर प्रॉपर लिम्फोसिंटिग्राफी इसके लिए 2 पॉइंट सबसे इंपॉर्टेंट है कि जो हम रेडियो कोलॉइड इंजेक्ट करते हैं उसका रैपिड ट्रांजिट हो लिम्फेटिक्स में, प्लस एंड उसका लॉन्गर रिटेंशन हो सेंटिनल लिम्फ नोड्स में और अदर लिम्फ नोड्स में। इसके लिए हम नॉर्मली 100 to 200 नैनोमीटर साइज हमारे लिए ऑप्टिमल होता है। मेनली 2 कॉमनली यूज रेडियो न्यूक्लियाइड और टेक्नीशियन 99 सल्फर कोलॉइड जिसकी साइज रेंज 15 to 500 नैनोमीटर होती है, एंड सेकेंड इज एल्ब्यूमिन नैनोकोलॉइड जिसका साइज रेंज 5 to 100 होता है। इन दोनों में से मेनली हम सल्फर कोलॉइड ज़्यादा प्रेफर करते हैं क्योंकि इसका वाइड वेराइटी ऑफ साइज है, और एल्ब्यूमिन कोलॉइड लेस कॉमनली यूज होता है क्योंकि कुछ पेशेंट में एल्ब्यूमिन एलर्जी हो सकती है। ये नेक्स्ट स्लाइड में बता दूँ। नाउ इंजेक्शन साइट, तो इंजेक्शन के लिए काफ़ी सारी अप्रोचेज हैं जिनमें से 2 अप्रोचेज मोस्ट कॉमन है, पेरी एरियोलर एंड पेरी ट्यूमरल। पेरी एरियोलर हमें मेनली सुपरफिशियल ड्रेनेज का आइडिया बेटर देता है क्योंकि एरियोला हमारा लिम्फ ड्रेनेज हाई लिम्फ रिच स्ट्रक्चर, एंड पेरी ट्यूमरल हमें एसेसरी ड्रेनेज का बेटर आइडिया देता है और 20 से 30% पेशेंट में देखा गया है में हमें इंट्रामेमरी चेन भी विजुअलाइज होती है। अदर अप्रोचेज हैं सबडर्मल, इंट्राडर्मल, इंट्राट्यूमरल और सबट्यूमरल. हाँ, इंट्राट्यूमरल अप्रोच यूजुअली उतना यूज नहीं करना चाहिए, क्योंकि इसके मेन कारण ये है कि क्योंकि ट्यूमर सेल्स मेनली है में ब्लड सप्लाई इंक्रीज होती है, तो अगर इंजेक्शन प्रॉपरली नहीं होगा तो रेडियो ट्रेसर मेनली ब्लड स्ट्रीम में चला जाएगा और उतनी एक्टिविटी वहां पे बचेगी नहीं. और दूसरा है कि देयर आर चांसेस ऑफ ब्लॉक lymphatic channels by tumor cell itself, तो हम प्रेफर मेनली पेरियोलर और पेरिट्यूमरल अप्रोच ही करते हैं. लिम्फोसिटिग्राफी के लिए हम मेनली 2 to 3 ml वॉल्यूम यूज करते हैं और 2 to 3 ml ही एक्टिविटी रहती है. और जैसे कि पहले इंजेक्शन साइट मैंने डिस्कस की, इंजेक्शन देने के बाद में पेशेंट का इमीडिएट फ्लो इमेजेस ली जाती हैं, उसके बाद में 20 मिनट्स में और 2 आवर्स में डिलेड इमेजेस ली जाती हैं. उसके बाद में इमेजेस में हम सेंटिनल लिम्फ नोड को मैप करके स्किन पे मार्क कर देते हैं. उसके बाद में पेशेंट को ओटी शिफ्ट कर दिया जाता है, जिसमें कि गामा प्रोब की हेल्प से हम लोग सेंटिनल लिम्फ नोड डिटेक्ट कर लेते हैं और वो बायोप्सी में असिस्ट करते हैं. नेक्स्ट स्लाइड. ये इमेजेस हैं. ये फर्स्ट इमेज स्पेट सिटी स्कैनर है, जिसमें कि इंजेक्शन देने के बाद हम पेशेंट को इन बिटवीन these 2 स्कैनर्स प्लेस करते हैं और प्लेनर इमेजेस ली जाती हैं, जो कि मैंने पहले डिस्कस किया, कुछ ऐसी दिखती है. मेन चीज है कि इन प्लेनर इमेजेस में हम सेंटिनल नोड डिटेक्ट तो कर सकते हैं, लेकिन उसका प्रॉपर लोकलाइजेशन थोड़ा मुश्किल है. उसके लिए नेक्स्ट स्लाइड. उसके लिए मेनली हमारे पास स्पेट सिटी हाइब्रिड इमेजिंग है, जो कि जिसमें कि हम न्यूक्लियर मेडिसिन पार्ट प्लेनर इमेज का जो है और सीटी का पार्ट कंबाइन कर देते हैं. फर्स्ट इमेज में 2 इमेजेस हैं जो कि एक्सियल सेक्शन पे हैं, जिसमें कि फर्स्ट इमेज में जो ब्राइट स्पॉट है वो मेनली हमारा इंजेक्शन साइट है. सेकेंड इमेज में जो ब्राइट स्पॉट है वो हमारा सेंटिनल लिम्फ नोड मेनली बताता है, जो कि इप्सिलेटरल साइड में है. एंड सेकेंड केस में, जो कि एक रेयर फाइंडिंग है, फर्स्ट स्कैन में इंजेक्शन साइट है. सेकेंड स्लाइड shows in tracer uptake at contralateral axilla, and due to high sensitivity and specificity, it should be considered as sentinel lymph node. These are pictorial representation की only sentinel biopsy कैसे की जाती है. After palpating the tumor, peritumoral injection is given at peritumoral region within 2 to 3 mm of region. उसके बाद में immediate flow images and 20 minutes और 2 hours पे images ली जाती है, जैसे मैंने पहले बताया. इमेजेस लेने के बाद में हम स्किन के ऊपर लिम्फ नोड की मार्किंग कर देते हैं और इंट्रा ऑपरेटिवली सेंटिनल लिम्फ नोड गामा प्रोब की हेल्प से हम लोग डिटेक्ट कर सकते हैं. जैसे कि इन इमेज में देखते हैं, गामा प्रोब को हम डायरेक्टली मार्क पॉइंट पे या फिर इंसिजन साइट कोई भी सस्पिशियस लीजन पे प्लेस करते हैं, जो कि सेंटिनल लिम्फ नोड की एक्टिविटी को मेजर करता है, जो कि ऐसे स्क्रीन पे हम लोग देख सकते हैं. तो इट हेल्प्स इन बेटर लोकलाइजेशन ऑफ सेंटिनल नोड एंड हेल्प्स इन बायोप्सी. अगर इसकी इफेक्टिव डोज की बात करें तो इसमें केवल 0.2 मिलीसीवर्ट का एक्सपोजर होता है, और वो भी मेनली फिंगर्स के लिए होता है. एंड फिंगर्स के लिए परमिसेबल रेंज ज्यादा है, तो इसमें कोई ज्यादा डरने वाली बात नहीं है सेंटिनल बायोप्सी. Now,
so the breast cancer, we know, is a systemic disease. So once it is diagnosed, it's always prudent to look for, though the primary lesion जो है वो हमें छोटा लग सकता है, but there is always a possibility that there are few cells which have localized somewhere in the body, and which may later on cause the problem. So before अगर हम कोई भी therapy start करते हैं, it is always advised to look for metastatic disease. So PET scan, this molecular imaging also helps us in screening the whole body so that we find out any metastatic focus which may be asymptomatic. So for that we have Dr. Reena Dhamija will describe about it.
Body imaging, molecular imaging is having whole body bone scan to look for whole body skeleton for spread of disease. And second modality is whole body PET scan, PET CT. Here, two radionuclides or radiopharmaceutically used. One is FDG PET CT, which is most commonly used, and this is only used almost everywhere. Second is estrogen PET CT, but this is not really used. This is just in a theoretical. And we are also discussing same FDG PET and bone scan here. Next slide. Now, whole body bone scan is required in almost all the breast cancer as a routine protocol, because on 1/3 of cases develop metastasis either at the time of diagnosis or later in follow-up. Bone metastasis most commonly seen is 80% in 80% of cases, but in cases in bone scan we are usually seeing osteoblastic lesion or the sclerotic lesion. Osteolytic lesion are difficult to find in bone scans. This whole body bone scan is a simple, safe, painless procedure. It is inexpensive also and non-invasive. And this is recommended for accurate staging of disease burden, also follow-up in symptomatic or high-risk cases in locally advanced breast cancer patients. How we are doing bone scan is we are using radiopharmaceutical, which is bone seeking analogs of calcium and phosphate. Most commonly uses technetium 99M MDP, which is methylene bisphosphonate. With this given intravenously, and this is localized at the site where increased perfusion and bone turnover is more. This is characteristic of bone metastasis, especially sclerotic. The mechanism how this radiopharmaceutical is getting uptake.
Yes, Dr. Reena, you can start.
Okay, so the procedure of bone scan is bone seeking analogs of calcium and phosphate. Technetium 99M MDP is administered, and wherever increased perfusion and increased bone turnover, it will localize there and it will show the hotspot as a osteoblastic lesion. What is the mechanism of uptake is? It is actually physicochemical adsorption or chemisorption. It is having very high sensitivity but of low specificity, that fracture, simple trauma, infection, inflammation can also show the soon uptake. Only by the history we can go for metastatic lesion. The preparation is almost none. Technetium 99M MDP is injected 20 to 25 millicurie intravenously. Good hydration is of course needed. And after injection, patient is allowed to take anything by mouth and also allowed to go for frequent voiding. After injection, we'll have to waiting period for 2 to 3 hours just to give time for uptake. And to avoid contamination, patient is advisable to void carefully, as this radiopharmaceutical is excreted through kidneys. So if urine is contaminated on clothing or skin, it will appear same as the disease. So it should be taken care of. Before scanning, patient is allowed to go void or empty the bladder just to see the pelvic structures clearly. Or something should be removed. This is how bone scan images are look like. The left one is whole body normal study of patient, whole body anterior and posterior projections. The right one is metastatic disease, anterior and posterior whole body skeleton. You can see multiple hotspots. The right elbow, that uptake is because of injection site. Rest other bladder, of course, physiological uptake, because this is the site of this is the mode of excretion. And you can see spine, ribs, and of course left femur that is showing abnormal, and pelvic region. These are all osteoblastic lesions of metastasis. One more interesting phenomena we are seeing into bone scan while following the patient after treatment, that flare phenomena. This is characterized by actually increased radiotracer uptake, which was not seen earlier in the same case. Maybe less lesion are seen, but after therapy, because of the flare of the or reactive response to the therapy, there is increase in osteoblastic activity, denoting as healing bone. And this flare is visualized on the whole body bone scan as exaggerated appearance of disease that is either representative of healing bone or previously invisible lesion. In either instance, visualization of flare response on bone scan may provide valuable prognostic information indicative of healing or progression of disease. Next slide. This is just to show the flare phenomena. This is first anterior posterior whole body bone scan baseline study that shows lesions into the ribs and all. This is metastasis. The middle picture, which is post 3 cycle, that is showing very increased number of lesion in almost whole body, ribs, spine, pelvis, peripheral bones, etc. The third post 6 cycle, when we followed this same case, there may appear regression of the disease. So the middle one either you can say flare up disease, flare phenomena, or could be an increased lesion which was not visualized earlier. But only with the comparison with the clinical history or clinical condition of the patient, we can realize that this is not actually an increase in the disease burden. This is because of therapeutic response, we are getting flare phenomena. Next slide. This is hybrid images, which is giving all over picture of a disease, including anatomy as well as physiology. There are 3 rows. Top row shows CT images, middle row shows nuclear images, and the last bottom row, which is actually a fused images, CT as well as uh, uh, nuclear imaging. And you see in the bottom image, you can localize lesion very well as compared to either one. So hybrid images is preferred, and this give both information, structural as well as functional. Now PET CT images, I request Dr. Nitin to describe this.
Thank you, ma'am. टॉकिंग अबाउट पेट सिटी, इसमें कि दोनों कंपोनेंट पेट सिटी और पेट और सीटी कंपोनेंट दोनों होते हैं, जो कि हमें कंबाइंड फंक्शनल इंफॉर्मेशन और विद एनाटॉमिकल डिटेल्स प्रोवाइड करते हैं, और इसमें एक्यूरेट एनाटॉमिकल रजिस्ट्रेशन भी होता है. पेट सिटी is mainly beneficial for staging, response evaluation, restaging, detection of recurrence, and follow-up during or after cytostatic therapy in cancer management. Next. अगर हम पेट सीटी के अपटेक की बात करें, तो जैसा कि हम जानते हैं कि कैंसर सेल्स का मेटाबॉलिज्म ज़्यादा होता है, इंक्रीज ग्लूकोज डिमांड होती है, इंक्रीज एंजियोजेनेसिस होता है, और उनके सरफेस पे ग्लूकोज रिसेप्टर का एक्सप्रेशन भी ज़्यादा होता है. इन्हीं प्रॉपर्टीज की वजह से एफडीजी का अपटेक ट्यूमर सेल्स में ज़्यादा होता है. ट्यूमर सेल के में एंटर करने के बाद में F18 एफडीजी नॉर्मल ग्लाइकोलाइसिस पाथवे फॉलो करता है, लेकिन हेक्सोकाइनेज 2 के एक्शन के बाद में ये F18 एफडीजी 6 फॉस्फेट में चेंज होता है, जो कि आगे मेटाबोलाइज नहीं हो पाता है. FDG 6 phosphate can be changed back to F18 FDG, and it can exit the cell by the action of glucose 6 phosphatase. बट कैंसर सेल्स में ग्लूकोज 6 फॉस्फेटेज की भी डेफिशिएंसी होती है, इसलिए मेनली एफडीजी ट्यूमर सेल्स में ट्रैप्ड हो जाता है। इसी की वजह से एफडीजी का मेनली अपटेक ट्यूमरल सेल में ज़्यादा होता है। मैम नेक्स्ट स्लाइड। सेल में एंट्री के बाद में F18 जो कि हमारा अनस्टेबल एटम है, वो प्रोटीन डिके में जाता है, जो कि एक न्यूट्रॉन, एक पॉजिट्रॉन और एक न्यूट्रिनो पार्टिकल इमिट करता है। पॉजिट्रॉन जो कि एक पॉजिटिवली चार्ज पार्टिकल है, ये नियर बाई इलेक्ट्रॉन से कंबाइन होके 2 एंटी पैरेलल 511 केवी गामा रेज और फोटोन जनरेट करता है, जो कि हमारे पेट डिटेक्टर के सेंसर से डिटेक्ट होती है। नेक्स्ट, अगर हम गाइडलाइंस की बात करें फॉर पेट सीटी फॉर पेट सीटी ऑफ पेशेंट विद ब्रेस्ट कैंसर, तो पेशेंट प्रिपरेशन के लिए मेनली हम पेशेंट को एडवाइस करते हैं कि वो स्कैन से पहले कोई भी हैवी एक्सरसाइज ना करे, ताकि हम मस्कुलर अपटेक को मिनिमाइज कर पाएं, क्योंकि जहाँ भी एक्टिविटी ज़्यादा होगी वहाँ पे ग्लूकोज का डिमांड ज़्यादा बढ़ेगा और वहाँ पे एफडीजी का अपटेक होगा। तो पेशेंट को एडवाइस करते हैं कि वो कुछ भी मिनिमम एक्टिविटी करे और आराम से बैठे। स्कैन के लिए मेनली हमें एटलीस्ट 4 आवर की फास्टिंग की जरूरत होती है, ताकि एफडीजी जो हम इंजेक्ट करते हैं उसका एडिक्वेट अपटेक हो पाए। पेशेंट को एडिक्वेट हाइड्रेशन मेंटेन करने की लिए एनकरेज किया जाता है, ताकि क्योंकि एफडीजी का मेनली रूट ऑफ एक्सक्रीशन रीनल होता है और एडिक्वेट हाइड्रेशन से अनवांटेड एफडीजी जो कि रीनल रूट में आ गई है वो इजीली फ्लश आउट हो सके। पेशेंट को वार्म इन्वायरमेंट में मेनली हम वेट कराते हैं इंजेक्शन के बाद में। उससे पहले भी पेशेंट को एडवाइस किया जाता है कि वो एडिक्वेट सही से कपड़े पहने, ताकि उसकी बॉडी वार्म रहे, ताकि हम ब्राउन फैट अपटेक को मिनिमाइज कर पाए। जैसे कि ये जो केस हमने डिस्कस किया था उसमें ब्राउन फैट अपटेक था। स्कैन के लिए हमें मेनली लेस देन 200 मिलीग्राम पर डेसीलिटर ब्लड ग्लूकोज लेवल चाहिए होता है, ताकि ये एफडीजी बायोडिस्ट्रीब्यूशन को अल्टर ना करे। एफडीजी एडमिनिस्ट्रेशन के लिए हम अपोजिट साइड की अपर एक्सट्रीमिटी में कैनुला लगाते हैं, ताकि हम इप्सिलेटर मतलब कैंसरस साइड की एक्सिला में आर्टिफैक्ट मिनिमाइज कर पाएं, क्योंकि अगर हम उसी साइड लगा देंगे तो कई बार हमको आर्टिफैक्ट्स मिलते हैं जो कि फॉल्स पॉजिटिव रेट इंक्रीज करते हैं। और फॉर स्कैनिंग के लिए हम आफ्टर 16 मिनट ऑफ वेटिंग इंजेक्शन के बाद में पेशेंट को कॉल करते हैं। और मेनली हमारा फील्ड ऑफ व्यू मिड बेस ऑफ स्कल से मिड थाई तक रहता है। ये कुछ इमेजेस हैं जिसमें फर्स्ट इमेज में हम देख सकते हैं कि मेनली पेट स्कैनर दिखता है कैसा है। ये बैकग्राउंड में व्हाइट मशीन पेट स्कैनर है और आगे ये मॉनिटर हमारा एक्विजिशन कंट्रोल है। राइट में ये पेट इमेजेस हैं, अभी तक तो आप लोग काफ़ी फैमिलियर हो गए होंगे इसके लिए। और राइट बॉटम में ये हमारा रेडियो एक्टिविटी कैरियर, क्योंकि F18 FTG हमारा साइक्लोट्रॉन जनरेटेड प्रोडक्ट है और हर जगह साइक्लोट्रॉन फैसिलिटी नहीं होती, तो इसको ट्रांसपोर्ट करना पड़ता है टू द डायग्नोस्टिक सेंटर। तो ये ऐसे शील्डेड बॉक्सेस में ट्रांसपोर्ट की जाती है। मैम नेक्स्ट स्लाइड। अब ये मैक्सिमम इंटेंसिटी प्रोजेक्शन इमेजेस हैं, जो कि एक 3D इमेज होती है, जो कि हमें बेसिक आइडिया देती है कि बॉडी के किस पार्ट में एफडीजी का अपटेक है। तो हम फर्स्ट इमेज पे आते हैं, जिसमें कि नॉर्मल फिजियोलॉजिकल अपटेक है ब्रेन और हार्ट में। किडनी और ब्लैडर में हमें इंक्रीज अपटेक मिल रहा है, क्योंकि इसका रूट ऑफ एक्सक्रीशन रीनल होता है। अपार्ट फ्रॉम दैट कुछ पेशेंट में हमें ओरोफेरिंग्स में और टॉन्सिल में इंक्रीज अपटेक मिल सकता है, जो कि मेनली मैक्सिमम केसेस में फिजियोलॉजिकली होता है। अब जबकि हम मतलब हमें बेटर अंडरस्टैंडिंग है कि नॉर्मल अपटेक एफडीजी में कैसा दिखता है, तो सेकंड इमेज में हम क्लियरली बता सकते हैं कि these lesions are metastatic lesions. नेक्स्ट इमेज। अगर लिमिटेशन की बात करें तो एफडीजी की सेंसिटिविटी कम है प्राइमरी ब्रेस्ट ट्यूमर में जिनका की साइज लेस देन 1 सेंटीमीटर हो, और कुछ हिस्टोलॉजिक सब टाइप लाइक लोब्यूलर ब्रेस्ट कैंसर में एफडीजी का अपटेक बहुत कम होता है इरिस्पेक्टिव ऑफ साइज। सेकंड, फॉल्स पॉजिटिव। पेट-सीटी में मेनली फॉल्स पॉजिटिव का कॉज होता है इन्फ्लेमेशन, जो कि किसी भी कारण से हो सकता है, चाहे वो पोस्ट सर्जिकल इन्फ्लेमेशन हो, ग्रेन्युलोमेटस प्रोसेस हो, इन्फेक्शन हो, पोस्ट कीमोथेरेपी इन्फ्लेमेशन हो, पोस्ट आरटी इन्फ्लेमेशन हो। कुछ फिजियोलॉजिकल ट्यूमर जैसे फाइब्रोएडेनोमा में भी इंक्रीज एफडीजी अपटेक मिलता है, जो कि फॉल्स पॉजिटिव हो सकता है, और फंक्शनल स्टेटस जैसे लैक्टेटिंग ब्रेस्ट में भी एफडीजी का अपटेक ज्यादा होता है। नेक्स्ट स्लाइड। Now talking about sensitivity and specificity of FDG PET in breast cancer. तो जैसे कि हमने पहले अभी डिस्कस किया, प्राइमरी ट्यूमर्स में इसकी सेंसिटिविटी एंड स्पेसिफिसिटी लो है। लिम्फ नोड्स के लिए एक्सिलरी स्टेजिंग के लिए इसकी सेंसिटिविटी लो है अगर हम कंपेयर करें सेंटिनल लिम्फ नोड बायोप्सी से, बट इसकी स्पेसिफिसिटी हाई है। तो अगर हमें कोई एक्सिलरी लीजन मिल रहा है तो उसको मेनली कंसीडर करना चाहिए कि ये मैलिग्नेंट हो सकता है, और एक्स्ट्रा एक्सिलरी और मेटास्टैटिक डिसीज के लिए बोथ सेंसिटिविटी एंड स्पेसिफिसिटी हाई है। मैम नेक्स्ट स्लाइड। Now talking about role of PET-CT in newly diagnosed breast cancer, when we compared with conventional imaging, तो FDG PET में फ्यूअर फॉल्स पॉजिटिव रेट होते हैं क्योंकि फंक्शनल और एनाटॉमिकल की इमेजिंग दोनों को कंबाइन करता है। इसके चलते हम एक डायग्नोसिस पे या फिर फॉलोअप स्टडी में फंक्शनल स्टेटस पे कि रिस्पांस है कि नहीं है, या फिर डिसीज कहाँ पे है, ये हम लोग जल्दी डिटेक्ट कर सकते हैं, जो कि इम्पैक्ट करता है शॉर्टर टाइम टू स्टार्ट थेरेपी। एंड विद दिस, क्योंकि हम थेरेपी जल्दी स्टार्ट कर पा रहे हैं, इट एड टू द लो एडजस्टेड कॉस्ट व्हेन वी यूज PET-CT. These are PET-CT image. In MIP, there is a increased tracer uptake at left elbow region, and a focal uptake at left axilla, जो कि हम लोकलाइज कर सकते हैं फ्यूज इमेज पे कि लेफ्ट एक्सिला में एक एक्सिलरी लिम्फ नोड में अपटेक है। तो अगर हम पहले प्रीवियस स्लाइड पे, तो ये एक क्लासिकल एग्जांपल है कि कैसे एक सिंपल मिस्टेक से फॉल्स पॉजिटिव रिपोर्ट आ सकती है। इसमें जो ये ब्राइट स्पॉट है जो लेफ्ट एल्बो पे दिख रहा है, ये ट्रेसर का एक्स्ट्रा विशेषण है जो कि लिम्फेटिक्स के थ्रू अपटेक होके लेफ्ट एक्सिला में पहुंचा है, जो कि लेफ्ट अपर लिम की सेंटिनल लिम्फ नोड है, जो कि डिसीज का प्रोसेस नहीं। इसी की वजह से हम लोग जब भी ब्रेस्ट कैंसर में कभी भी इमेजिंग करते हैं तो हम अपोजिट साइड की एक्सट्रीमिटी, अपर एक्सट्रीमिटी को चूज करते हैं ताकि इस टाइप के फॉल्स पॉजिटिव रिपोर्ट ना हो। और this is a case of 43-year-old female with pre-PET-CT stage of 2B invasive ductal carcinoma and previously unsuspected distant mass. तो इस स्कैन में MIP में मल्टीपल इंक्रीज ट्रेसर अपटेक हैं राइट ब्रेस्ट में, लेफ्ट ब्रेस्ट में, लेफ्ट एक्सिला में, और मल्टीपल फोकल हैं लीजन्स हैं लीवर में, जो कि हम एक्सियल इमेजेस में भी देख चुके हैं। तो यहाँ पे PET-CT इम्पोर्टेंट रोल प्ले करता है, क्योंकि PET-CT से पहले क्योंकि पेशेंट कोई डिस्टेंट मैच का सस्पिशन नहीं था और ये 2B स्टेजिंग थी, तो स्कैनिंग के बाद में डायरेक्टली अप स्टेज होकर 4th स्टेज पहुंच जाएगा, जो कि ट्रीटमेंट मैनेजमेंट में काफी इंपॉर्टेंट। Now talking about evaluation of treatment response. So there is a strong correlation between early changes in FDG, maximum SUV, and new adjoint response when measured at pathological level. And treatment response in metastatic disease, conventional image में treatment response mainly measure होता है, majorly depend करता है size और characteristic of lesion से. But FDG PET में metabolic changes में mainly better predict treatment response than anatomical changes. इसका example हम आगे देखेंगे. ये baseline और after therapy, chemotherapy scans है 41-year-old female with invasive ductal carcinoma. Baseline में जैसे कि देख रहे हैं कि CT इमेज में कोई लीजन नहीं है, लेकिन सेम पेट CT इमेज में फ्यूज इमेज में एक इंक्रीज फोकल अपटेक है लेफ्ट एल ऑफ सेक्रम में, जबकि आफ्टर थेरेपी फॉलो अप स्कैन में CT में स्क्लेरोटिक लीजन है सेम साइट पे, बट पेट CT इमेजेस में कोई अपटेक नहीं है. तो मेनली ये शो करता है कि मेटाबॉलिक एक्टिविटी लीजन की मेनली ज्यादा इंपॉर्टेंट है रादर देन एनाटॉमिकल चेंजेस. जैसे कि फॉलो अप स्कैन में जो ये स्क्लेरोटिक लीजन है, ये मेनली शोज बोन रिमॉडलिंग ड्यू टू हीलिंग. जैसे कि हमने पहले बात करी कि इन्फ्लेमेशन मेनली फॉल्स पॉजिटिव रेट्स के लिए मेन कॉज होता है. तो कब हम बोलेंगे कि एक पर्टिकुलर लीजन मेटास्टैटिक है या इन्फ्लेमेटरी है, तो उसके लिए हमें एक क्वांटिफाइंग टूल चाहिए. इसके लिए हमारे पास SUV है जो कि स्टैंडर्डाइज अपटेक वैल्यू है, जो कि एक पर्टिकुलर लीजन की मैक्सिमम SUV अपटेक मेजर करता है. लेकिन SUV का अभी तक कोई एक क्लियर कट ऑफ नहीं है जिससे कि हम ये बता पाएं कि पर्टिकुलर लीजन इन्फ्लेमेटरी है या फिर मैलिग्नेंट है. इसके लिए डिफरेंट अप्रोचेस एडवाइज की गई हैं, जैसे कि डुअल पॉइंट इमेजिंग, जिसमें एक एडिशनल डिलेड इमेज ली जाती है, जिसमें कि कई बार ये देखा गया है कि जो इन्फ्लेमेटरी लीजन है उसमें FDG का अपटेक कम हो जाता है, जबकि मैलिग्नेंट लीजन उसको रिटेन करते हैं. और another is concept of metabolic signature. Am I audible? Another is concept of metabolic signature, जिसमें कि मेन कॉन्सेप्ट ये है कि किसी भी प्राइमरी मेटास्टेटिक मैलिग्नेंट डिसीज में और उसके मेट्स में ऑलमोस्ट कंपेरेबल SUV एक्टिविटी होती है. बस इसमें भी अगर कोई लीजन सब सेंटीमेट्रिक साइज का है तो उसमें SUV क्वांटिफिकेशन मुश्किल होता है. तो एंड में मेनली जो चीज हमें सबसे ज्यादा हेल्प करती है ये बताने में कि इन्फ्लेमेटरी लीजन है कि मैलिग्नेंट लीजन है, वो है रिलेवेंट पेशेंट हिस्ट्री एंड सिम्टम एंड करस्पॉन्डिंग CT इमेजेस. जैसे कि अभी जो केस डिस्कस हुआ उसमें वेज शेप कंसोलिडेटरी लीजन था राइट अपर लोब में, क्योंकि वेज शेप कंसोलिडेटरी लीजन टिपिकल होता है इन्फ्लेमेटरी या फिर इन्फेक्टिव चेंजेस के लिए. और फिर भी अगर इक्विवोकल या फिर सस्पिशन रहता है तो हम फॉलो अप स्ट्रेटजीज अपनाते हैं, जिसमें कि फॉलो अप पेट CT से भी कर सकते हैं और कन्वेंशनल इमेजिंग से भी कर सकते हैं. जैसे कि अभी केस डिस्कस किया जिसमें कि लंग रीजन है, उसका हम फॉलो अप CT पे कर सकते हैं आराम से अगर हमें सस्पिशन होता तो. नेक्स्ट स्लाइड. नाउ कमिंग टू रेडियोलॉजिकल प्रिंसिपल. According to ARB, for optimization of radiation exposure, LARA principle is followed. LARA mainly stands for as low as reasonably achievable. पेशेंट के एक्सपोजर के लिए मेनली इंपॉर्टेंट होता है कि हम बेनिफिट टू हार्म रेशियो हमेशा ध्यान में रखें. डोज लिमिट्स की अगर बात करें तो ऑक्यूपेशन एक्सपोजर के लिए 20 मिलीसीवर्ट पर ईयर एवरेज ओवर 5 इयर्स, या फिर एक ईयर में 30 मिलीसीवर्ट एनी ईयर में परमिसिबल रेंज होती है और जनरल पब्लिक के लिए 1 मिलीसीवर्ट पर ईयर। नेक्स्ट स्लाइड। नाउ कमिंग टू रेडिएशन एक्सपोजर इन डिफरेंट मॉडलिटीज। रेडियोलॉजी में मेनली हेड सीटी 1 to 2 मिलीसीवर्ट, जिसमें कि मैक्सिमम रेडिएशन एक्सपोजर है, जबकि हम बड़े एरिया को कवर करते हैं, जैसे कि एब्डोमिनल पेल्विक सीटी अगर हम करें तो 8 to 14 मिलीसीवर्ट का एक्सपोजर होता है। और न्यूक्लियर मेडिसिन टेक्निक्स की बात करें तो इसमें पेट सीटी और सिंटी मैमोग्राफी का सबसे ज्यादा रेडिएशन एक्सपोजर है। पेट में 18 to 22 मिलीसीवर्ट का एक्सपोजर है, सिंटी मैमोग्राफी में 6 to 9 मिलीसीवर्ट का एक्सपोजर। तो जैसे हमने प्रीवियसली बात करी कि ऑक्यूपेशनल एक्सपोजर के लिए हमें 20 मिलीसीवर्ट पर ईयर का रेंज है, वो रेंज इसलिए है कि इससे ऊपर रेडिएशन हैजार्ड होते हैं और इन फ्यूचर कैंसर होने के चांसेस ज्यादा हैं। और ये उन पेशेंट्स पे भी अप्लाई होता है जिनका हम स्कैन करा रहे हैं, जबकि मेडिकल एक्सपोजर के लिए एज सच पेशेंट्स के लिए कोई लिमिट नहीं है, लेकिन फिर भी इन टेक्निक्स को हमें जुडिशली यूज करना चाहिए कि कितना इंफॉर्मेशन हमें इससे मिल रही है। कि जैसे कि अगर हमें किसी पेशेंट का होल बॉडी मेटास्टेटिक वर्कअप कराना है तो उसमें चेस्ट सीटी, एब्डोमिनल और पेल्विक सीटी कराने के अलावा एक होल बॉडी अगर पेट सीटी स्कैन हम कराते हैं तो ज्यादा इंफॉर्मेशन मिलेगी और रेडिएशन एक्सपोजर कंपेरेबल। नेक्स्ट स्लाइड। Now coming to National Comprehensive Cancer Network Guidelines for PET CT. In 2019, it allowed optional use of FDG PET for initial staging of locally advanced disease and evaluation of treatment response by stating that it may be helpful in identifying unsuspected regional nodal disease or distant metastasis. And it is most useful in situations where standard staging studies are equivocal or suspicious, especially in the setting of locally advanced and metastatic diseases. Now, Dr. Reena will conclude the presentation.
Thank you, Dr. So to conclude, nuclear imaging, it fills a physiologic niche in medical imaging for cancer patients, providing information representative of functional and is a fundamental component of disease diagnosis, treatment, as well as prognosis. Specifically for breast cancer care, general nuclear medicine supplies diagnostic value at each stage of the disease and is considered first-line modality in multiple clinical scenarios. PET-CT has emerged as a powerful oncologic tool, and with the advent of targeted radiopharmaceuticals is predicted to undergo a highly anticipated expansion in the management of breast cancer. And in the end, there is the word theranostics. This term is recent advances in cancer treatment in addition to diagnosis. So diagnosis as well as therapeutic. So the term comes as theranostics. This is now very useful in nuclear medicine. Thank you.
So that was a very comprehensive presentation as far as nuclear medicine is concerned. What we are concerned and what looking at the futuristic aspect of things, where are we headed? We need to introspect and find out. I think the next pandemic in the world is cancer. Cancer is the next pandemic. पहले ऐसा सोचा जाता था किसी किसी को कैंसर हो जाता है, फिर आया कि हाँ दूर दराज के रिलेटिव्स को कैंसर होने लगा, अब तो हर घर में आ गया. So in spite of whatever we are doing, in spite of however we claim कि हम बहुत आगे पहुंच गए हैं, we need to introspect कि कहीं हम कुछ बहुत बड़ी चीज मिस तो नहीं कर रहे हैं. That's my take on cancer. इसलिए whenever we are looking at whenever I look at cancer, I look at a Daivik Adhyatmik angle of cancer. It does not, what happens in the body is the Annamaya Kosh. It is possible that the disease has started in the Pranamaya Kosh, Manomaya Kosh, Jnanamaya Kosh, or Anandamaya Kosh, and translated into the physical body as a tumor. So, however much you remove the tumor, it's going to come back again. We will rename it as metastasis and things like that. We need to introspect and come to a conclusion. Can we use these modalities to actually help a patient come out of the disease process? Stopping a cancer is a miracle in itself. Making the cancer take a U-turn is a miracle in a miracle in a miracle. From a U-turn, patient का बिल्कुल कैंसर निकाल देना is unthinkable. We should introspect and think about it. That's my take on cancer. Yes, Dr. Sudhi, I hand it over to you.
Yes, sir. It's fine. Thank you very much, sir. And I must admit that I'm very much thankful to my team members, and I really learned a lot while we were preparing for this presentation. I really learned a lot. I'm very thankful to all the participants who took out their precious time and make it happen. So why we took this topic? Because there were a lot of controversies that we were going around, and we took the opportunity of this meeting. Why not to discuss in this forum and to invite the experts in their field and to see their comments कि ये क्या होता है, कैसे होता है. So the important things that first of all, before we go on to our queries, sir, I request Geeta ma'am and Dr. Aftab to put some light on the way we manage the case. हमने जो केस मैनेज किया, जिस तरह से मैनेज किया, जो हमारी रिपोर्टिंग थी, न्यूक्लियर मेडिसिन रिपोर्टिंग थी, व्हाट डू दे थिंक अबाउट दिस रिपोर्ट, दिस केस मैनेजमेंट? क्या वो वैसा ही करते या कुछ डिफरेंट करते अगर वो पेशेंट उनकी फैसिलिटी में आता तो? So may I start with Dr. Geeta first, ma'am?
Thank you, Sudhi. I've sat through the entire presentation, and I think some great insights from the nuclear medicine colleagues. So my take on the case is, Sudhi, it was a small tumor. So I'll just take it point-wise. So you did an FNAC. FNAC was a C4. Basically, it said suspicious of malignancy. So before going in for a wide excision, I would have definitely gone in and done a core biopsy. It was a small tumor, but it was definitely visible, looking quite pathognomonic on ultrasound also as a very hypoechoic, irregular lesion. And what is visible on ultrasound can be biopsied, is as simple as that. So I think I would have done a ultrasound guided core biopsy, because eventually you landed up not addressing the axilla at all. So there is nothing to say as of current evidence that you can leave the axilla alone and subject it to radiation alone. Mm-hmm. After you've done a sentinel node biopsy, you can debate if it is a single node positive or two nodes positive. You can debate whether you want to do a completion axilla, or you want to just leave it alone, or you want to do radiation to the axilla. So that is where it would be. So that is how we would have done slightly differently. And on the ultrasound also, the lesion was very small. Clinically also, you had staged it as CT1. So in a CT1, I would be very loath to do a PET CT. It is a stage 1 disease. So nobody should, if there are students on this program, they should not go back with the idea that a stage 1 deserves a PET CT. But we live in times, especially in practice, patients would just come and ask for it, and then you'll end up doing it. So that is a common scenario. So a lot of times, even in a stage 1, we'll end up doing a PET CT, whether you believed it was necessary or not. And so what you saw on the PET, well, it looked like a pretty strongly FDG avid lesion, I thought, on the images that you showed, whereas your reporting said it was non-FDG avid, which I find a little difficult to accept, because it is visibly there, and I'm sure all my colleagues would agree that there was definitely a very strongly FDG avid lesion on the right side, and there were some faint FDG avid nodules I thought I saw on the left side also. I don't know what they were. They may just have been something which is innocuous. And of course, the consolidation that you picked up, well, this is the problem with PET also. Incidental findings like this can actually land up over-investigating a patient, putting a patient through a lot of harassment that is actually not meant to be. In fact, in a T1 situation, you can just completely do away with any kind of staging. Stage 1 and a stage 2A. Up to a stage 2A, you can actually not do any staging at all. The pickup rates of any investigation, it could be an ultrasound or a bone scan, is a 0, and an ultrasound is a 1 to 2% in a stage 1. So, you can jolly well not do a staging in a stage 1. Forget PET altogether. So that is for discussion. The other thing is, I'm not very convinced that PET is a great investigation for the breast. For staging, of course, say 2B upwards, I definitely would do PET, because node positive disease is a different ball game altogether. So there I would think, yes, we should consider a PET CT. Node negative, I keep my reservations. I discuss with the patients, and despite telling them, oh, you may just not have to do a PET, they will still go ahead and do it, because even if I don't say it, somebody else will say it and they will do it. So otherwise, for me, that is where I start. A node positive disease is where I would start considering a PET, not earlier than that. And for a breast, I would say an MR mammogram is definitely the tool to fall back on, because it gives you anatomical, it does give you kinetics, it does give you the diffusion curves, that gives you a lot of information. I would not, a PET CT cannot throw up non-mass-like enhancement. It will not show you all of that. So an MRI is definitely the tool to fall back on if you want more information, especially in young patients where the breasts are dense. So in a dense breast, I would actually not do a PET CT till I have a diagnosis of cancer, period. Meaning until I get a diagnosis I do not do a PET to make a diagnosis. I would do it after I've got a histological diagnosis of breast cancer. That is when I would do a PET, because that is the second step. Diagnosis, staging, treatment. That's how it works. The other thing that was mentioned was about Sinti mammo. So we used to, when I was in Rajiv Gandhi, but that was quite a few years ago, almost about 15 years ago, was the last Sinti mammogram that I had the pleasure of seeing. But since then, we have done no Sinti mammogram. But it is a good tool. At the time that PET was not there, I think Sinti mammogram was quite a useful tool in figuring out what was happening in the breast, especially in dense breast. It used to happen. At that time, we didn't even have an MR mammogram. So, we are in the process of evolution, and a lot of things are going to change. What I'm saying today may not hold water tomorrow, and possibly we may land up doing PET for all patients and not stick in a needle. All of those things may happen in the future, but as of today, the gold standard will still be a histopathological diagnosis followed by staging as we see it. And even for assessing response to treatment, I would still fall back on an MRI rather than a PET CT. And I can assure you, PET CT is not a great investigative tool for lymph nodes. See, that is the problem with MRI also. But MRI has made leaps and bounds in terms of spatial and temporal resolution. But PET CT is still a bit slow in the spatial resolution bit. So that is why it is possibly not a great tool. The sensitivity is pretty low, in its 60s, as far as axillary nodal information is concerned. And like Dr. Nitin put up in his last slide on the NCCN guidelines, you yourself contradicted a lot of things in that last slide where you said that, locally advanced breast cancer. Agreed. Assessment of response in metastatic disease. Agreed. PET CT is the tool that I would like to go to. But then you have to be very judicious about, and see, you yourself said that the annual amount of radiation for a person is 20 millisieverts, right? And you're exceeding it with a single PET CT. And sometimes as clinicians, we just forget that bit, and a patient is undergoing a PET CT every 3 months. So what are we doing? So we have to strike a balance. Don't forget, it is a human being that you're treating, and you have the responsibility to ensure that the patient doesn't come to any harm, because we are trying to address our own fears. So the fears are many. So, why did the PET MR not take off? If PET MR was the next big thing, why did PET MR not take off? Because possibly PET MR was picking up almost 25% of patients were getting upstaged without any clinical change in outcome. So I think that is why PET MR never took off. So PET CT is that we do today. Otherwise, these are my observations. I may have forgotten a couple of things, but I think overall, there were a lot of learning points, and I'm sure Dr. Aftab will also like to add to what I have said. Thank you.
Okay. So, ma'am, before I go to Dr. Aftab, may I request you to please elaborate what are your reservations with PET scan? Because one very common scenario is that most of the clinicians, breast surgeons, they feel like once the breast cancer is diagnosed, because it is not hard and fast that in early breast cancer the incidental metastatic lesions are not detected. We do see such cases, the incidental second malignancies, incidental metastatic lesions, even in early breast cancer. So majority of the clinicians, they think of like, once the patient is diagnosed with breast cancer, just screen the patient with a modality which give a complete screening of the body, so that we are sure that we are not missing out any internal mammary lymph nodes or any other incidental metastatic lesions, which are very usually difficult to diagnose with the conventional imaging modality. Because before initiating therapy, they think that like we know from where we are starting the treatment, so that later on, if these things are detected, the patient may or our attendant may not think that we have missed out anything. So what are your reservation? Is it the radiation exposure, the amount of radiation exposure, or anything else also?
So, Sudhi, we cannot be addressing our fears. Our fear does not translate into science. We have to follow recommendations. Like I said, tomorrow the recommendation may change, but as of today, there is no recommendation which says that stage 1 should be staged with a PET CT. There is nowhere. Because, you will get these incidental findings. If you're practicing somewhere, I'm practicing, a third person is elsewhere, they will all pick up these ones. I have had situations where, I was not planning a PET, the patient got the PET done, there was a concurrent breast ovary or a breast rectum. So you do come up with these things. But these are your fears, but nobody can fault you. If I were to not do a PET CT in a stage 1, nobody can fault me, because there is no recommendation to say that I should be doing a PET CT in stage 1. Show me the recommendation which says, so you're basically fighting your fear. Micrometastasis, even your PET cannot pick up. Your PET also needs a 5 millimeter disease to show up. So what is PET going to do? You'll find a subcarinal lymph node which is shining nice and bright, and you're stuck, and you tell the patient you have to do a bronchoscopy guided TBNA. That costs the patient a lot of money, 30,000 she spends, and it comes back as nothing, reactive lymphadenitis. But the patient has been through hell and back because you've just told her that you may be metastatic. So, it is a fine balance. See, clinical practice is not, addressing our fears. It is doing the best for your patient, which may be less and not more. So I think you in your mind have to be clear, convey to the patient exactly as it is, because it is not necessary to get it right. That's the what do you call, I say, the contradiction of medical science. It's not an absolute science. It is not 2 + 2 is 4. Every human being is different. Every individual is different. And you will get these surprises. You will kick yourself and say, "Kya kara dete PET." But that's not the answer. That's that one patient. But another 1,000 did not show up anything, or another 10,000 did not show up anything. But for that one patient, you will feel bad because you did not pick it up. That's fine, because it was not part of a recommendation.
Okay, so ma'am, just a quick question. In early breast cancer, what are your modalities of staging of the patient? If ever you stage, how do you stage? What are investigations you ask?
I would do, so Dr. Naveen also said that if your conventional imaging is suspicious or is ambiguous, that is when you would fall back on a PET CT. So I would do an ultrasound abdomen, an X-ray chest. X-ray chest would anyway be done. And I would do a bone scan if at all. In a stage 1, possibly not even a bone scan. In a stage 2A, maybe a bone scan also. 2B onwards, I would volunteer for a PET CT. But stage 1 and 2A, I would stick to. But lots of times, I'm telling you, just now I have a patient who has a 1.6 centimeter tumor, small tumor. I got an ultrasound abdomen, X-ray, and not even a bone scan. Sent her back saying that she should come back for surgery. But then, of course, she went around looking for second opinions and third opinion. And somebody offered her a PET. She got a PET done, same. nothing, stage 1 disease, but that is the way it is. So if I don't say it, somebody else says it, and the patient does get it done eventually. So that's a day-to-day thing. So you can't change that.
Yeah, thank you very much, ma'am, for your inputs. And now I request Dr. Aftab Hassan Nazar to please give his opinion, his suggestions, and his insights into all this discussion.
Okay, good evening everyone, and thank you, Dr. Sudhi. So the first thing I would like to become critical, as Dr. Geeta said, there was no indication. This tumor clinically was T1, around 1 centimeter in size. So there was clearly no indication. So when I was reading indication of PET-CT in early breast cancer, so there was a line, I picked it up: unnecessary FDG PET causing delay in the therapeutic management and cause unnecessary anxiety. So this patient actually fit in that line. And also I like to quote a study, multicentric, that has around 300 patients. Out of 300, FDG picked around 13% positive. And that 13% only 3 was true positive, other was negative. So there was no indication in stage 1. Indication started with locally advanced breast cancer. But then in India, unfortunately, we don't practice evidence based. We practice defense based. So this could be a reason everyone is coming with the PET-CT. So I would like to share you one example. Like when I was resident and senior resident, so when I meet any senior consultant oncologist, so he always say, "See, look, I don't want PET-CT. I have done my practice without PET-CT when I was learning, so I don't rely on PET-CT. But when I meet my resident, onco resident or surgical onco resident, so he always say, yeah, without PET-CT, I cannot move." So Dr. Gita, so this is the change which is going on. The new resident and new students, they are totally depend upon PET-CT, whether this is indicated or not, because this is something fear. There's fear of missing out something that is actually happening in our field, and also litigation from the patient that we are aware of. Okay, so this thing is done. Then now come to this patient. Why PET was reported as negative? So as Dr. Nitin said, a small tumor can be negative. I would add a small tumor and the slow growing tumor. In this case, that was not negative. This scan was not negative. This was slow or say small FDG avid lesion. So I don't know what was the SUV max of this lesion, but by the image, I can say this was mild FDG avid. Then again, for the nuclear medicine physician and the clinician, when you are interpreting a PET-CT, this is the not scan you are reading. You should read whole history, whole patient particulars. This patient has a nodule which was fixed to the nipple areola complex. So here is the clue. This nodule is fixed. So this has high probability to be malignant. So while reporting, you have to more suspicious and you have to more bias toward malignancy. Second thing, FNAC was positive. So definitely you should be more suspicious when you are reporting this. Then second thing, it picked up a false positive finding. I would say this was positive, not false positive. Again, go back to the history. This patient has a history of tuberculosis and she has taken ATT. So you should know she had taken ATT. She should have somewhere patches of infection. And then come to the why FDG was positive in that small focus. So there could be mild inflammation going on nearby that could say the FDG avidity. So you go by the CT and the PET, both findings. CT was characteristic, fibronodular, pleural based, and wedge shaped. So this point toward the infection, and you have a history of the infection also. So this is not false positive, this is true positive for the infection. So these two things I think I have
Okay.
answered it. Then come, okay, may I speak?
Yes, sir, please.
Okay, so now I come to Dr. Geeta concern about radiation exposure to the patient. So what Dr. Nitin said, limit of radiation exposure 20 millisievert. This is for healthcare professionals who are giving radiation to the patient. Nowhere it is mentioned what is the radiation exposure limit to the patient. What principal nuclear medicine does, as low as reasonably achievable. So we do patient scan, we give exposure to the patient, but within the limit, as low as possible. But there is no limit. We have to outweigh risk versus benefit ratio. So this is about radiation exposure thing, and false positive, false negative thing. And if there is anything.
Yes, sir. So the thing is, this radiation limit for healthcare professional, I think, because they are the high risk people, the nuclear medicine physicians and all. So this 20 millisievert in a year for 5 consecutive years, or 30 in 1 year, suppose. So this must be the high limit. So I think if we do PET scan in any patient, we are consuming that high limit in one single exposure only. So we are already giving a very high exposure of radiation to the patient, and I think it is not justifiable. Like, we should be very judicious in doing PET scan in any patient. So my point as a clinician, we all the clinicians are always confused about this SUV max. Though Dr. Nitin tried his best to explain about it, we are always confused. If at all, at any point in time, we ask for a PET scan, and suppose there is some cranial lymph nodes, those are positive. Though we try our best, like, to correlate with the primary lesion and other thing, but we just want to understand from you, how do you interpret any report and say whether it's inflammatory, it looks like more of inflammatory or malignant, please.
So this SUV max has no value when differentiating malignant from the benign disease. First
Okay.
thing. Second thing, we have to look on the pattern. So if the patient has a right breast CA, right axillary lymph node, then right internal mammary lymph node, then she has prevascular lymph node and mediastinal lymph node, then I can make out this is the channel. Tumor goes to axillary lymph node, internal mammary, then prevascular, then mediastinal lymph node. So this is the pattern. But if I see primary tumor, only axillary lymph node, and then suddenly I see a subcranial lymph node, then definitely there is a red flag. This is not clear-cut metastasis. So we have to follow up this case. We should not clearly mention it as a metastasis. But if the patient came for the staging, and besides primary, we see a lot of metastasis, then if there is even rectoperitoneal lymph node and liver metastasis, then definitely this could be metastasis. The only thing is the pattern we have to see.
Okay, so it's not only the SUV max, the whole pattern that we see, we correlate it clinically, and because most of the time we find a problem, हमें जो problem आती है वो mediastinal lymph nodes को लेके होते हैं, whether we should get a biopsy. And this point is very well taken. The points that we now understand more is that this PET scan, though it is a good modality, but it is a very high radiation exposure risk. And secondly, whenever we ask for it, there are very high chances of picking up false positive results, which may unnecessarily create anxiety in both the
Yes.
doctors,
As
clinician, as
you
well
are
as the
you are a surgeon, you must have learned when you are in doubt, give benefit of doubt to the patient. So if you have a lymph node which is not fitting in the story and you are in doubt, give benefit to the patient and go for radical surgery.
radical surgery. Fine. So, ma'am, if I can ask you, suppose now that patient if comes to you this patient has this story. She had a centrally localized lesion where the lesion was widely excised, but the sentinel lymph node biopsy is not done. So we are not sure whether the lymph nodes are really negative or only negative on imaging or clinical palpation. So what is your take? Would you like to go ahead with the radiation to the axilla, or would you like to do something else for this patient? Hello? Geeta ma'am?
Oh, sorry, you're asking me. Okay.
Yes ma'am.
So,
मैम आपसे एक क्वेश्चन है कि सपोज अब यही पेशेंट आपकी फैसिलिटी में आता है इन केस, और this patient already had a wide local excision of the lesion with a luminal type A histology.
yeah.
So with a clinically node negative axilla, but sentinel lymph node biopsy not done. So what is your take? Would you like to go ahead with the adjuvant radiation therapy directly with hormone therapy and follow this patient, or would you like to do something else in her case? You have
So I
seen
will
the
do a sentinel node biopsy. I will still do a sentinel node biopsy.
So now if this patient comes, so you would like to stage the axilla while doing the
Of course.
sentinel. So I
Yes,
think you
certainly.
will be putting some intradermal dyes because the tumor is already gone.
So that's fine, because see, now it is very clear. It does not matter where you inject the isotope or the blue dye, whether it is periareolar, peritumoral, intraparenchymal, subdermal, it does not matter. There are enough trials to show that whichever route you do, the results are pretty much the same. So I would do an intradermal injection, the isotope injection, as well as a blue dye, and it will be proximal to the scar. It has to be proximal to the scar. If you do it distal to the scar, doesn't make sense because the lymphatics are already gone. So no point in doing that. So we do it a lot of times. We do get patients who've had lumpectomies done, and we had to go back and revisit the axilla, and we have done that quite successfully.
Okay, so certainly you would like to give this benefit of doubt, like you would like to do a sentinel lymph node biopsy, even though her primary tumor is out. And then you will decide upon the axillary status and further therapy.
See, this is, even in a stage 1, you do have a 4% to 5% chance that the axilla may be involved.
Yeah.
So I would definitely want to stage the axilla.
Okay, so ma'am and Dr. Aftab.
And the other thing is, once I've staged the axilla, if it is negative, then there is going to be no radiation to the axilla. There will only be radiation to the breast.
And suppose if it comes out to be positive?
See, we fortunately have frozen section facility. So if on frozen section, we have done about 4 sentinel nodes and 1 turns out to be positive, small metastasis, I may just leave her alone also.
Okay.
1 out of 4. And then you don't have to specifically treat the axilla, even if it is 1 out of 4 lymph nodes positive.
Okay, ma'am. Ma'am, for the sake of all our participants, can you please elaborate? Like, if you are planning for a sentinel lymph node biopsy, अगर आप sentinel lymph node biopsy plan करते हैं, so what is your protocol? Do you go for a radioisotope with methylene blue, or you usually go for methylene blue with a indocyanine dye? Like, what is radioisotope for you?
So we don't have ICG. I have done a few cases with ICG, but I'm most comfortable with the radioisotope because I think the radioisotope is not hindered by depth, by the size of the patient, whereas ICG is. So, and I have, for the past 22 years, I've been using the combination. Earlier we used to have patent blue, but now we use methylene blue because it is easily available and it does as great a job as the patent blue. The only thing that one has to be careful about is that don't do an intradermal injection of methylene blue because then you are running into serious trouble with flap necrosis. So just keep it subareolar and do the injections there because then you don't run the problem of flap necrosis. So I use a dual technique, and so we must have done about 2,000 odd sentinel node biopsies in the past 20 years.
Okay, fine. Thank you very much. So, and Is it the same technique, same protocol that we inject and then we do a lymphoscintigraphy and then the patient is sent into the OT?
So, we don't use sulfur colloid. So Dr. Nitin was mentioning sulfur colloid. Sulfur colloid stays for long, but in our, in one of our facilities where we do not have the gamma camera, we have to get the isotope from INMA. So we still get sulfur colloid from there. So we do the injection in the evening, and the first case in the morning is the case. But in our other facility, we have sodium phytate, and that's what we use, and technetium phytate or so nanocolloid. So one of the two we use, and that you really don't have to wait because nanocolloid travels very fast. So you can actually take up the patient within half an hour of injection with nanocolloid. So, but sulfur colloid gives you more bandwidth, like you said. You can wait longer. It stays for longer because it is got a higher weight.
So maybe in some of our other session, we will do a dedicated session on sentinel lymph node biopsy. So, sir, now that we are at the end of our session, a very quick question from my side. What is the current protocol in SGPGI? Are we doing sentinel lymph node biopsy with radioisotope? And if at all, if we are using, how frequently, and what is the protocol that is being followed there?
Okay, so we are routinely using this sentinel lymph node. So we inject sulfur colloid to the patient one day before, say in the evening, and next day patient in the morning OT first case is taken, and they have handheld gamma probe. So with the handheld gamma probe, they can make out which lymph node is having higher activity, and that is labeled as a sentinel, and that is taken out, sent for forensic. So if
So do you do lymphoscintigraphy before sending the patient to OT or after injection somewhere to see whether it is really in the ipsilateral axilla or it is in internal memory or contralateral axilla, which is very unusual, but it may happen.
Once a while we do scintigraphy imaging, but honestly speaking, endosurgeon does not use that image. He mainly rely on the gamma probe.
So lymphoscintigraphy is given up. It is not to be done. It is not required to be done.
Yes,
so the
I
past
agree.
6-7 years we have not done. The only situation where you may want to do it is if you're doing a recurrent SLND.
Okay.
In a recurrent situation, because there your lymphatic channels may be here, there, everywhere. So that is where you may want to do a lympho. That is the only indication now left for a lymphoscintigraphy in when you're doing a sentinel node.
Okay, and so what is the protocol? How do we identify that this particular lymph node is the hot lymph node? Because it must be, the dye must overnight, like in 8 hours, must be taken up by so many other lymph nodes as well. So what is the exact criteria you identify that this particular lymph node is the hot lymph node and the other is the background activity?
Okay, so this handheld gamma probe is taken to near to the lymph node. Then which lymph node is going maximum count? So gamma probe will go the beep.
Mm-hmm.
So maximum sound, where they catch maximum sound, they take up that lymph node.
So any
yeah. And the other thing is, you would put the probe on the primary where the injection was done, and then 10% of the background count. That is what would qualify as a hot node. But see, once you've done 2-3 lymph nodes, there are sometimes you continue to get activity. But then there would be one node which would be, say, 6,000 or a 1,500. And there would be another node which would be, say, 200, 300. And then you would still get some activity like a 70, 100. So you can ignore those nodes. You don't have to. So it has to be the highest activity node and then 10% of the highest. And then maybe if there is an enlarged suspicious node, that is what would constitute your sentinel node.
Thank you very much for all the information. May I request the forum, if anyone wants to ask any question from our experts, the forum is now open for discussion. Any of the participants, they want to ask any question from I hope all the questions that have been come into my notice are being answered by our experts. And since our we are just on time, and I'm very thankful to all my team, Dr. Chani, Dr. Nitin, Dr. Reena, Dr. Meena. I'm thankful to our guest faculties, Dr. Aftab Hassan, Dr. Geeta ma'am, and our moderator, Dr. Avdesh Pandey, and all the participants. Some of the participants are very routine, or like they are routine participants. I'm very thankful, and I always elated with their presence and cheered up with their presence. And this time also they have joined. Thank you very much, Dr. Seladurai, Nitika ma'am, Dr. Malika, and all everyone. And this session was really very interesting. I learned a lot. Like other session, this session also taught me many lessons. The main purpose of this forum is to upgrade the clinical skills, the existing clinical skills with most of our clinicians. Because of lack of any regular academic platform, we tend to forget, and we just flow in the rhythm like what others are flowing into. So through this forum we upskill ourselves, and this our agenda is achieved for today. I'm very thankful to our experts who have taken out their precious time on a very short notice. Also, they participated and they contributed a lot. And with this, I would like to end this meeting with an information that in March, that is an odd month, and we have an endocrine meeting pending for that day. We have a very interesting topic of hormonal assays, which will be discussed with the help of experts who regularly do such assays, and they will tell us the various protocols, how we should do, what are the various protocols, हमें कैसे करना चाहिए, क्या उसको false positive है, false negative है. हम इन सभी के बारे में बहुत ही विस्तार से और बहुत अच्छे से चर्चा करेंगे, ताकि नेक्स्ट टाइम कभी हम एड्रीनल, पैराथायराइड या इस तरह के किसी और सैंपल्स को, थायराइड के सैंपल्स को जब हम तो हमें ध्यान रहे कि हमें किन किन चीज़ों का ध्यान रखना है. और आप लोग उस सेशन को बिल्कुल ज़रूर से अटेंड कीजिएगा. जो भी लोग एंडोक्रिनोलॉजी या एंडोक्रिन सर्जरी से रिलेटेड है, उन सभी से मेरा रिक्वेस्ट है कि आप सभी उस सेशन को ज़रूर एंजॉय कीजिएगा. बहुत सारे अच्छे नए इंटरेस्टिंग टॉपिक्स के साथ हम हर महीने फिर मिलेंगे. इसी के साथ मैं आप सभी का धन्यवाद देना चाहूंगी. बहुत बहुत धन्यवाद आप सभी का. Have a good night, and with the promise that we will meet again. Thank you, ma'am. Thank you.
Thank you for having me.
Few words for the program, if you can give, so it will be a motivation for all our participants, all our speakers. आपको ये प्रोग्राम कैसा लगा? छोटा सा इनिशिएटिव है, ऐसा मैं नहीं कहूंगी कि बहुत है, लेकिन हमारे इस प्रोग्राम में इंडिया के हर पार्ट से लोग जुड़ते हैं और हमें बहुत पॉजिटिव कमेंट्स देते हैं, हमें फीडबैक्स देते हैं. ये एक छोटे से हमारे लिए बहुत बड़ी चीज होती है ये चीज. अगर आप लोगों का भी हमें थोड़ा सा फीडबैक मिलेगा, हमें हेल्प रहेगी अपने आप को इम्प्रूव करने के लिए.
So this is a very nice program, and as I can understand, like I see you are in like private hospital, so definitely you will be missing academic things. What I or people who are in academic institute that enjoy. Okay, so but you have keep it up, like this activity you are constantly touch with the academic activity. So this is good thing and very nice thing. I have learned very much, and also I saw Nitin. He was SR when I joined SGPGI. So after 4-5 years, I can see this Nitin and and Dr. Pandey, and I think he has left the meeting. But thank you, Dr. Pandey, for having a nice introduction of mine and SGPGI. So if you people ever come to the Lucknow, so you are most welcome. Be my guest, not only for SGPGI, but when you are in Lucknow also.
Thank you very much. Whenever I visit Lucknow, I always visit PGI because that's my alma mater.
Okay, so next time when you are here, please see me.
Certainly, okay, it will be my pleasure.
Okay, thank you everyone. Thank you.
Thank you. Yeah, Geeta ma'am.
So thank you very much for having me on board this program. I think it's a great academic activity. I think, we need to put the spanner in the works, because otherwise everybody thinks, that we are doing things in a certain way and that's the right way of doing it. So there are no rights and wrongs. And like I said, medical science is not absolute. But, a bit of tweaking here, there, and it is actually, how you deliver it on ground, because, a lot of times you have to tweak recommendations, guidelines, so that, it suits your patient. It fits right for that particular patient. So every patient is unique. And there are times that you have to tweak a bit here and there. And I think that is completely understandable and allowed. But I think at the bottom of it, everybody should carry the message that we have to do what is in the best of interest. We have to get the optimum, information from whatever we do. A lot of times you'll see, patients going for an MRI without realizing that we're not asking for a body MRI. We're asking for a breast MRI, and you need a dedicated breast coil. So, there are small things that, which doesn't possibly get across to people, but I think programs like this will actually bring out those nuanced points which need to go to every clinician who practices oncology. And oncology is multidisciplinary. If you have a doubt, just go down to your nuclear medicine specialist, just sit with him or her, figure it out, find out what is your conviction. A lot of time their conviction is right. So I always do that, with my nuclear medicine. I'll ask him, patient could have come back query metastatic, and I sit down and talk to him. He said, lag nahi raha, meko to benign lag raha hai, and most of the time he's proven right. So, obviously your conviction grows. Unless you have that conversation with him, you will think, oh, jo likha hai wo le liya, or don't take anything at face value. That's the great thing about medicine. Try and look beyond the script. What is presented to you, uske pare dekhne ki koshish kariye. So it was a great experience, and I'd surely love to join more sessions whenever it happens. Thank you.
Thank you. Thank you very much. So now I conclude this meeting, and with the promise that we will meet again in subsequent meetings, maybe with some other topics, some interesting topic. Thank you.
Thank you.
Thank you.
Good night to all. Thank you.